Thank you everyone for being here today. Like Dr. Cohen said, today I speak about the preoperative things that we do specifically in the clinic before total joint arthroplasty, focusing primarily on the knee and the hip and the shoulder. Some background info since I'm the first speaker. I'm sure all of you who practice and work with total joint replacement patients, you're noticing that the average age of patients getting a little bit younger. Total age of patients definitely stemming younger. We see a lot of men in their 40s getting hip replacements, as well as older patients who are desiring to maintain a healthier and active lifestyle in their 80s. And I think the oldest patient I saw was an 88-year-old knee replacement patient. She was probably one of the best patients I ever had, actually. The average hospital stay is shorter, 3 to 4 days, with the rehab stay typically longer. So again, patients are getting younger and older, and the studies are showing that the rates of revision are definitely higher among younger patients. Indications for total joint arthroplasty are pretty commonsensical. Severe pain that impedes your work and everyday activities, significant stiffness, advanced joint breakdown seen on imaging, an unacceptable loss of function. Every patient we see pre-op is struggling with the decision to have a joint replacement. And I tell them, you know what, you'll know when you know. When should I have it done? There's no rule. You'll know when you know. When you can no longer function at the level that you desire to function at, and the doctors are willing to replace your joint, then you will have that joint replacement. The role of physical therapy, primarily it's three-tiered. In our practice, we're going to definitely talk about physical readiness and try to restore range of motion and strength and mobility as much as possible. A lot of education. I say 90% of what I do, I teach, and only about 10% is physical therapy, and a lot of mental preparation as well. So physical readiness, I always educate my patients about weight loss. The studies do show that there's an increased incidence of rates of manipulation, increased revision rates among morbidly obese patients, and with patients with a BMI greater than 30, they're associated with decreased range of motion and functional outcomes after joint replacement. But that same study by Young did say that these patients with BMIs greater than 30, they have the same, in functional outcome studies and surveys, they have the same sense of fulfillment and satisfaction from their joint replacements as patients with a BMI less than 30. So the hardest thing is facing a patient who might be morbidly obese and telling them, let's try to lose weight, when they can hardly move because their joints hurt so badly. But we do as much as we can. We educate them about nutrition and exercise, and we do as much as we can to lose as much weight as possible. But at the same time, it's important to understand and remember that their outcomes, although are typically less by these studies, their sense of fulfillment and satisfaction are the same. So you can tell them you're probably still going to get the same pain relief as someone who is not morbidly obese, but let's work on trying to improve your overall function before you go into surgery anyway. So normalizing mobility, range of motion, and strength is the primary goal when a patient's coming to you in the clinic with a planned joint replacement. With knee replacement patients, we want to focus on gaining extension, mobilizing the kneecap, as much flexion as possible. With hip replacement patients, there's a picture of basic hip motion, but I focus a lot on the hip flexors and the adductors, which are typically the tightest muscles for a patient with severe hip OA. But having tight adductors and hip flexors will limit how strong you can get the abductors and the extensors after surgery, and those are the muscles that you have to try to get as strong as possible after surgery. So really lengthen those adductors, those groin muscles. And for shoulder replacement patients, we just try to restore as much motion and glenohumeral mobility as we can, and strengthening the rotator cuff and scapular stabilizers before surgery. Some basic knee strengthening exercises. You start with mat-based or floor-based exercises, or gravity eliminated. You work on quadricep strengthening. You do what you can tolerate. Most patients know that they have this impending joint replacement coming, so there's no need to push it through the pain. They're going to be getting the joint replaced anyway. You just work within their tolerance and you try to get as much strength as possible. Bridging and working the glutes and the glute max, glute med, hamstrings, preparing to do some balance work, and just get them as strong as possible to prepare for this major surgery. For shoulder replacement patients, we work on retraction, the stabilizing muscle groups of the rotator cuff and the scapula, open up their chest muscles, try to improve their range of motion as much as possible. Betsy, I hope you don't mind I use those pictures again. And And now I want to talk about interesting studies. Obviously, this being a medical education conference, I go through and put all these pictures about all the exercises that I do standardly in the clinic, and then I do my research, and I find out there's no research to support that doing prehab actually works as far as improving functional outcomes after the surgery. So this specific study, this meta-analysis systematic review by Gill, they found pain and self-reported function, walking speed, and muscle strength were not significantly different in patients who had had a prehab or preoperative program compared pre and post compared to patients who didn't have a preoperative program. Specifically for knee replacement patients, whereas there was a trend towards a difference in hip replacement patients, that they had improved outcomes after surgery because they had done the prehab, which I thought was interesting. Another, and these are both published this year, another systematic review by Hugenboom, they found no difference for total hip and total joint, or total knee and total hip replacement patients who had had a prehab versus, and then had their outcomes assessed pre-surgically and post-surgically. But the biggest finding was that they found not one good quality study out of probably over 1,000 studies they reviewed that could really demonstrate a possible difference there. So what do we think about all this? I think there are tons of studies in the rehab literature and the orthopedic literature that link improved function and decreased pain in patients with mild to moderate arthritis. Whether or not you have it 2 months right before your surgery, but somewhere in the spectrum of this is impeding my function and I probably will have a joint replacement. We see a lot of patients in the clinic who have just had their Euflexa injections, or they're just got an OA unloader brace and they know that a joint replacement might be in their future, maybe 3 to 5 years. They're the patients who will do really well with an exercise program. They're the ones who are going to have decreased pain and improved function with therapy and working on their mobility. Perhaps not right before surgery, it might not make a difference for their outcomes, but in that planning time and that preparation time, at least it might improve their quality of life. So the second thing we work on besides physical readiness is education. That's just a picture of our clinic. I always look at this picture, I think it looks like a classroom or like a teacher's picture, because that's what we do as physical therapists. We educate our patients. You know, they come in with questions about assistive devices and safety issues and how are they going to get in and out of their car after hip replacement. We probably spend a majority of our teaching time while we're stretching and hands-on, just educating our patients. We do a lot of education in that preoperative phase. Mental preparedness is an interesting topic. A lot of studies are being done on mental health and mental well-being with healthcare. Chronic pain patients, back pain patients, pre-op patients, osteoarthritis patients, and how their mental health or state of mind affects their overall function. So this was a study back in 2002, expectations of complete pain relief and expectations of a low risk of complications improved outcomes after surgery, but also improved overall satisfaction with the surgery. And I read this and thought, well, yeah, if you go into it with a positive mindset and you have pretty good positive expectations, you end up having a better sense of fulfillment. It makes sense, but you'd be surprised how many patients come in dreading it, preparing themselves for horrible pain. I know it's going to hurt, you know. So talking to patients about mental preparedness is important in our preoperative phase. Another study, Scott et al., and they found that younger patients with lower preoperative scores on function had greater postoperative scores and greater fulfillment, which is not surprising. Total hip replacement patients meet expectations typically more than total knee replacement patients, but higher preoperative mental health scores had greater fulfillment after the joint replacement. So again, just speaking to their state of mind and mental health, and obviously that's not my expertise, but most patients are not necessarily seeing regular psychiatrists or social workers, but just talking to them about how they cope with stress and how they manage pain in general, and trying to troubleshoot and find some healthier ways to deal with that perhaps might improve their functional outcomes after surgery. So in conclusion, our role as physical therapists and the allied health professionals that see patients before their joint replacements, we obviously want to improve their health, talk about weight loss and nutrition, improve their overall physical abilities, range of motion, strength, and joint mobility, educate the family and the patient, also their family and caregivers about what to expect, both before and after surgery, but also mentally prepare them, talk about their coping mechanisms and their stress behaviors, and see if we can't prepare them as good as we can for their total joint replacement. Thank you.